Physiotherapy plays a crucial role in orthopedic medicine, especially when joint hypermobility or decreased range of motion is detected. Mobilization techniques, including joint and soft tissue mobilization, are essential for restoring movement. This chapter introduces joint mobilization techniques and emphasizes the importance of understanding anatomy, kinematics, and musculoskeletal disorders for effective therapy. Joint mobilization is a slow, repetitive, rhythmical, oscillatory movement performed by a therapist within the available range of motion, using various grades under the patient's control. There are two main types: arthrokinematics, which refers to movement at the joint surface, and osteokinematics, which refers to movement of the bones. Arthrokinematics describes the movement occurring at joint surfaces, known as joint play movements. The main types are rolling, sliding, gliding, spinning, traction, and compression. Each type has specific characteristics and occurs in different joint scenarios. Rolling occurs when new points on a moving surface contact new points on a stable surface, often between flat and curved surfaces. Gliding happens when the same point on a moving surface contacts new points on a stable surface, typically between congruent surfaces. The direction of movement depends on whether the moving surface is convex or concave. The convex-concave rule states that more congruent surfaces favor sliding, while more incongruent surfaces favor rolling. When a concave surface moves on a convex surface, rolling and gliding occur in the same direction. When a convex surface moves on a concave surface, rolling and gliding occur in opposite directions. This rule guides the direction of mobilization techniques. Spinning involves rotation of a moving surface on a stationary axis, resulting in rotatory movement. Traction is the pulling apart of articular surfaces, increasing joint space and reducing friction. Compression is the pushing together of articular surfaces, common in weight-bearing joints, but overcompression can lead to joint deterioration. Osteokinematics refers to visible bone movements such as flexion, extension, abduction, and rotation. Joint mobility is graded from 0 no movement to 6 unstable joint, with grades 0-2 considered hypermobile, 3 normal, and 4-6 hypermobile. Mobilization is indicated for hypermobile joints but contraindicated for hypermobile joints. Osteokinematic movements include flexion, extension, abduction, adduction, rotation, circumduction, supination, pronation, inversion, eversion, plantar flexion, dorsiflexion, and various bending motions. These movements are classified into rotatory, angular, and translatory linear motions. Movements occur in specific planes and axes. The frontal, coronal plane divides the body into front and back, sagittal plane into right and left, and transverse, horizontal plane, into upper and lower parts. Each plane is associated with specific axes and types of movement. Joints have specific positions: loose packed, resting, zero, starting, actual resting, used in pathology, and close packed, maximum congruency, and tautness. Resting positions allow maximum joint play, while close packed positions restrict movement and should be avoided during mobilization. Each joint has defined resting and close packed positions. For example, the shoulder's resting position is slight abduction, while its close packed position is maximum abduction and external rotation. These positions are important for assessment and treatment planning. Joint surfaces receive nutrition from synovial fluid, which circulates due to joint movement and compression. Normal mobility maintains tissue extensibility and prevents contracture. Joint receptors provide position and movement sense and are activated by different stimuli, contributing to joint health. There are 4 types of joint receptors: type I, Ruffini, for postural sense; type 2, Pacini, for dynamic sense; type 3, Golgi, for inhibitive response; and type 4, free nerve endings, for nociception. Each type responds to different stimuli and is located in specific joint tissues. Diseases like rheumatoid arthritis and osteoarthritis, injuries, immobilization, and overuse can all impair joint function. Each affects different joint structures, leading to pain, reduced range of motion, contractures, or instability. Mobilization can help restore function in many cases. Mobilization is indicated for post-traumatic, post-operative, or post-demobilization stiffness, adhesions, atrophy, and painful joints. Contraindications include synovial effusion, hemarthrosis, recent fractures, dislocation, acute inflammation, malignancy, and hypermobile joints. The stress-strain curve explains tissue response to external force. Elastic phase, returns to normal, plastic phase, permanent deformation, and failure point tissue tear. Mobilization should be performed within the plastic range but not beyond the second tissue stop to avoid injury. The treatment plane lies over the concave joint surface and moves with it. Gliding and rolling tests are performed parallel to the treatment plane, while traction and distraction are performed perpendicular. This helps determine the grade of joint movement. Key principles include ensuring patient relaxation, proper fixation of adjacent joints, support or stabilization of the moving part, correct treatment direction, parallel or perpendicular to the treatment plane, and appropriate force and range based on joint stiffness. Mobilization techniques are graded based on motion and joint play. Traction involves slow, perpendicular movements to the concave surface, graded I to 3 for pain reduction and extensibility. Oscillation involves slow, parallel movements, graded I to V for pain relief, extensibility, and breaking adhesions. Specific mobilization procedures are described for each peripheral joint, including the sternoclavicular, acromyoclavicular, scapulothoracic, shoulder, elbow, wrist, hand, hip, knee, ankle, and foot joints. Each procedure details the type of joint, articular surfaces, ligaments, movements, positions, and step-by-step mobilization techniques.